Good morning, everybody. Welcome to this morning's webinar on provider collaboration, realising the benefits and bringing people with you. My name is Miriam Deakin. I'm the Director of Policy at NHS Providers, and I'll be chairing the session for today. This is actually the fourth in our series of virtual events on provider collaboration. It's part of a new programme of work for us to try and help you respond to the challenges that you're facing. And as ever, today's session will focus very much on peer learning, and we'll be trying to draw out the practical insights and the practical steps from our colleagues on our expert panel. So do please feel free to treat this as a safe space and take the opportunity to ask our panel members any questions about their experiences that you want to and eke out the full benefit. We've got a really fantastic panel again today, and as ever, although the national policy narrative around provider collabs is a little bit focused on acute and mental health collaborations, we're really interested in all forms of provider collaboration, so cross service and across all of the sectors. And again, we've got quite a varied and diverse set of arrangements to talk through today, which is really good. So I'm delighted to welcome our panel for today. So warm welcome to Alan Burns, who's the chair of University Hospitals Northamptonshire, which is in the Northants Health and Care ICS. Welcome to Dr. Ify Okocha, the interim chief exec of Oxleas NHS FT, which is in South East London. And welcome to Sam Allen, who's currently still chief exec of Sussex Partnership, NHS FT, in the Sussex Health and Care Partnership. I think we're shortly about to lose you to up north for a chief exec role at ICB level, aren't we? So congratulations, Sam. It's great to have you here today. So welcome to all of our panellists. In terms of running order, we'll hear from each of our panellists in turn, and then we'll pause for time for questions and answers from yourselves, and hopefully we'll have a little bit of time towards the end of the session for some Q&A across the panel as a whole as well. So just to do the compulsory Zoom housekeeping, we are recording this session, so that's so that we can play it back to you, but also send it to a broader audience that might be interested as well. So just to be aware of that. If you could keep your mic, I'll try and notice anyone doing that. Use the chat function as much as you like as well. So do feel free to put comments in the chat. We'll capture all of those. And if you'd rather place a question in the chat, I'll keep an eye on that and ask your questions via the chat function as well. If you'd like to be on camera, it's lovely to see your faces, but appreciate it's busy and sometimes it's easier just to listen in off camera. So we'll leave that call with you. But if you'd like to come on camera, that would be lovely as well. And we will be doing a write-up of this session at the end as well, so don't feel too compelled to take notes. We can share all the information that's shared at the end of the session. So I think then, without further ado, I'm going to come to the first of our presenters today, which is Alan, just to give us a run through of his recent experiences in bringing people with the Trust as it formed its provider collaborative arrangements. Alan, thank you. I'll hand over to you.
Okay, thanks, Miriam. I thought I'd break with tradition and not do a large slide deck, slightly slide decked out in ICS land. So I thought I'd just do what my chief exec calls a chairman's riff on what it is we did. So as Miriam says, I'm the chair of University Hospitals in Northamptonshire, which is Kettering General Hospital, which KGH, which is a foundation trust, and Northampton General Hospital, NGH, which is an NHS trust. And that's just a little added complication. Two middle-sized DGHs, 16 miles apart, with a history of failed attempts at collaboration over many years. One hospital or the other always blocked it, often at board level. There was no love lost between them. Competition was the model. And so there's absolutely nothing new there. That's common all across the country. I was appointed chair of KGH in August 2017 after it went into special measures, and NGH just over a year later, December 2018, with a clear intent of driving collaboration to secure a future for both hospitals. Both were regarded as fragile. Some small steps had been taken before I took up the NGH job, but neither hospital was performing really well, and some services were definitely at the very extreme fragile end. making recruitment very difficult. So what did we do? Well, we held a joint board meeting, which sounds stunningly obvious, but my predecessor as chair at NGH had blocked this before, saying they always ended badly, which kind of tells you everything you need to know, really. And then we held a large, inclusive, very large, very inclusive clinical conference in November of that first year. The clinicians agreed they were up for collaboration. They were wary after all the failed attempts before and felt they'd been marched up to the top of the hill and they didn't really want to waste any more time. And the board's meeting, or several meetings really, agreed that the purpose was to improve clinical services. So other benefits might flow, but the driving force was service improvement. It wasn't going to be centralization. It wasn't going to be saving money. It wasn't going to be back offices. It wasn't going to be anything else. It was going to be service improvement. So we used some consultancy to review and agree some front-running specialties. That was probably important just for neutrality, really, at that point. And we picked them either because they were fragile and at risk of falling over. They had poor patient satisfaction due to poor processes or lack of cooperation or whatever. Or they offered an opportunity to improve if they came together. So we chose breast, ENT, and cardiology, one for each of those reasons, really. The cardiologists were delighted and pointed out that if we did actually come together, they'd be bigger than Oxford's cardiology department. So you've no idea what a big deal that was. So we started to explicitly plan some services on the basis of a population of just over 800,000, not two populations of 400,000. And we were very clear from the start that we had to fit with all the guidance on volume, quality, incidence, prevalence, COG guidance, everything else. But that changed to thinking about 800,000 population and talking about the services that happened then was really very powerful. It opened up a lot of clinical conversations. So about this time, the boards decided if this was to work, we needed a single chief exec. And I can go into some of the arguments for that if you want me to. And then along came COVID. So that was about 14 months into the exercise. And in that year that we'd had to develop our support and thinking, I think there were three really important decisions. First one was the prime purpose is improved clinical services. Keep saying it. Second, we would remain as two acute hospitals leading acute care in the north and west of the county, both with the emergency departments, both with maternity units, and whatever else that implied. And thirdly, we would take advantage of the opportunities of collaboration. And to do that, we would appoint a group CEO, and to remove the blocks on collaboration, as identified in the clinical conference, we'd appoint a group chief digital information officer, a group chief financial officer, and a group chief people officer. And I think those three decisions taken together meant there was absolutely no opposition to these plans. There was some nervousness, as you might expect, from staff in the areas where we were appointing group EDs. The CPO was appointed first, just because the opportunity arose, and the CEO was appointed in April 20 and took up post in July last year. So next, well, a lot of work, as you do. I always enter this sort of slightly wearily, really, you know, mission, values, priorities, strategies for the group, and massive amounts of staff engagement and partner engagement, governors at KGH, patient groups. But it is really important. And I was genuinely surprised by the way the staff engaged with this. The two hospitals have a combined staff of about 11,000. And we had 25% of our staff actively took part in some of the debates about mission, vision, values, etc. And when we started doing staff briefings for the group, or Simon Weldon did, the chief exec, which I joined from time to time, we regularly got 10% of our staff coming in on those briefings with open questions and open chat forums and so on. So it really did sort of engage people. And out of that came the priorities, and out of that came the strategies. So the strategies for people, digital, finance, estates, and academic. And the academic strategy was a big deal. And last of all, just this month, the clinical strategy. And you know, you could well sort of enter into an argument about the running order for those strategies, but we thought that it was important to show what the group stood for and how the enabling or the blocking issues were going to be addressed before we got strong-based clinician involvement. And I think we were right, but again, you could argue either way. There was no doubt the academic strategy was a large part of the proof that we meant this. And we meant this is a bit of a mantra, or we mean this is a bit of a mantra for us. So most of the strategies were agreed by the spring of this year. We launched a group, New Status of University Hospitals, in July. I say that was a big deal for a whole variety of issues around we mean this. Lots achieved, or being achieved, I think. Two big drivers, two new committees, Group Digital Committee, because we were horribly naive digitally. We were in a horrible place digitally. Both hospitals were really. You know, that really has shifted. And again, living proof that we mean this kind of thing. And a collaboration program committee. Both of those were chaired by non-execs, and both were crucial in driving the change. So we now have an agreed clinical strategy, creating centres of excellence for cardiology at KGH and etc. Cardiology, etc. at KGH. And the etc. in many ways is the important bit, because that's the bit that's going to move around and develop as the centre for cardiology and associated specialties. And for cancer at Northampton General, NGH, we have a model for addressing fragile specialties, which sounds trivial, but it's actually going to make a big difference. We have agreement on plans for a single elective hub, which would never have happened before. We have changes to ENT, one of the first specialties, which have really seriously improved patient safety and patient care. We have an academic strategy, and we have university status. And a long time ago in my life, I sat on the central R&D committee for the NHS for about 8 years. And you know, I am absolutely convinced the benefits of research and development, university status, the biggest single drive for quality and recruitment. It's the biggest single thing you can do. We have agreement that staff can move freely between the trusts, just agreed. We're just starting a single staff bank. We're moving to one IT system and a single login on cloud-based, which actually at that point you start to lose my understanding of what all that means. But nevertheless, it is a big task, and it's made, again, real proof that we mean this. Alignment of pay scales, and that's just ouch, really. You have no idea how variable the pay for a porter can be, or a domestic, or anything else really, and what the grading structures can be and so on. If you're going to move staff or allow staff to move, you have to start thinking about that. And then kind of more human things like common ID badges just starting, and amazingly car park access. You know, everybody sort of looked at me a bit funny about car park access, and I said, look, we're a group and we can't actually get into each other's hospitals. So you have to be part of a group, and you have to welcome each other, and you have to, I think you have to pay attention to the human factors, this sort of emotional stuff that goes with this. You can't just ride roughshod over it. Less successfully, well, we're still struggling to do something about breast services. All sorts of arguments about trivia, really. There's still some very tricky governance issues, committees in common, the usual stuff. Agreeing performance metrics. I don't think you can do committees in common until you've agreed your performance metrics. And I think the different boards at the start had 120 different metrics, of which 87 were calculated differently, although they were called the same thing. So, I mean, these things are just necessary precursors to beginning to understand each other and do compare and contrast stuff and learn from each other and so on. And the whole business of trust versus group responsibility. I'm a non-exec of this hospital, not of these hospitals, and you have to think quite carefully about how that plays out. Hopefully we'll get the governance sorted in the next 6 months, and I just think you have to accept clumsy governance, or at least time-consuming governance and processes develop. And the other thing that was really difficult was holding on to that model we agreed. We were going to be 2 acute hospitals providing services in different parts of the county, taking advantage of collaboration. It's really difficult to hang on to that model through rapid change, and you get new non-execs and new EDs, and just getting the balance between group and trust leadership is just a perpetual problem, really. What did it feel like? Well, it felt like going down a water slide. It's not something I do very often anymore, but it did feel like going down a water slide. Varying speeds, slightly out of control, smooth and fast, then bumpy and scary. And worst of all, you're not quite sure what it's going to feel like when it ends. And that's still what it feels like. It still feels like a water slide. In fact, it feels like a bigger one than it did at first. The pace of change post-COVID is driving lots of opportunities. So I think everybody looks back and says, I'm glad we are where we are. And that's, we're bringing services together to plan and deliver the ideas that emerged from the ICS. And in our particular case, it's only one county ICS. So we are the acute provider and we will lead the acute elective collaborative. So we become commissioner and provider for elective care, or at least leading commissioning and providing for elective care with partners in the system. So that's a major opportunity, but it's also a major challenge in the sense of, we've really got to take advantage of this. We've got to show we're better than what we went before. Lessons, well, quickly, we mean this. Keep saying it. It just becomes a mantra. We mean this, we mean this, we mean this. It's really important. And that means unified leadership. We can't have silent dissent. We can't have people going out of the room and saying they don't really. Our purpose and our test remains improved clinical services. And we can start to show that now. But if that's not what happens, then we haven't done what we said we would do. You have to pay a lot of attention to mission, value, and strategies and all that stuff, and show you're not deviating from them. These are long-term decisions. We spend our money in support of strategies. We don't spend it on other things. That's another version of we mean this. When the boards agree a strategy, we expect things to happen. So progress is monitored relentlessly. That's the collaboration program committee. Really important in driving progress. Hold lots of conferences, partly because, they're quite good to bring people together, but more so because it forces people to report on progress. It's a bit like COP26 or an EU summit. If you tell people they're going to have to stand up in front of 100 people in 6 months' time and tell them what they've done, then there's a reasonable expectation they'll have something to say at that point. So it does sort of drive that business of you have to be showing you're making progress here. And I think gentle competition and reassurance helps. There's a lot of nervous people out there around how's my service going to be at the end of this? How's my specialty? What's my career? All the rest of it. So gentle competition and reassurance helps. As ever in the health service, it'll be slower and harder than you think it will be. You can't overdo staff engagement, partners, governors, patients, public, local elected representatives. And we did all this as the county council was collapsing into 2 new unitaries. So we had to put even more effort into these people we mostly never met before. You have to gain trust. And it's easily lost. If you deviate from your promises or just change unilaterally, and that comes back to that model. Remember the model. We are 2 acute trusts, EDs, MAT units. We are going to take advantage of collaboration. We're not going to build a new hospital in the middle. We're not going to move ED. So holding on to that model and do not deviate from it. Misunderstandings, as ever, are easily created and less easily resolved. And I suppose when I was thinking about this, I was thinking, what above all would I say to someone? And the answer is be consistent and persistent. I actually really like those 2 words, and I think they're about what chairman ought to be, really. So be consistent and persistent. Thanks very much, Miriam.
Thanks, Alan. That was a fantastically frank and insightful summary of your journey. So really helpful. Thank you. I'm just going to start with a question from the chat, which was actually in my mind as well. But colleagues, if you've got questions for Alan, do either raise your hand using the raise hand function, just wave or put something in the chat. But Mike's put an interesting observation here, Alan. So when you were, as you were saying, you were describing the model and being both consistent and persistent around that. It sounded like that was very much a model of 2 organisations coming together as equals, whereas a lot of organisations experience difficulty, don't they, if one partner perceives the arrangement as a bit of a takeover. I wonder if you could just unpack the thinking around that a little bit more for us, maybe in terms of how you arrived at the model, whether that was evident or whether there was ever any other option on the table, and maybe how you managed some of the sort of engagement and comms around that to reassure people that it was a partnership of equals, I guess.
Well, just to put that in context, NGH is bigger, Northampton is bigger, it's older, it's bigger, and it probably, well, it has a little bit more tertiary stuff, and used to, if you history lesson coming, used to be part of Oxford region and thought of itself as part of Oxford medicine. An important part of Oxford medicine is how it thought of itself. And now, of course, it's part of the Midlands and East Midlands and connected to Leicester. Kettering is a smaller hospital and always felt looked down upon by Northampton. And indeed, at the time of the merger, Kettering had just come out of special measures and gone into RI status. And Northampton at that time was rated good, although I think most people regarded that as a bit of an optimistic rating. On the other hand, Kettering was the FT. So if this was going to come together, then technically it would be an acquisition by Kettering. And I think most people, I think my view about it was that both hospitals thought pretty much the same of each other. Both thought they were overbearing, smart ass, and rather cleverer than they thought they were cleverer than they thought they were. I think that, I mean, both were just critical of each other. So I don't know if equals is the word, but at the time, probably Kettering was a little bit on the downside of that debate. Had there been another model? Yes, there had. The previous model, which had been around in the county for quite a long time, was we were going to build a brand new hospital somewhere in the middle. And when I became chairman, a lot of people came and said, well, that's the plan, chairman. And I said, and how long has it been the plan? And he said, oh, it's been planned for years, which raises a kind of obvious question. So how come it hasn't happened yet? I just went off and asked a lot of people, really. I asked a lot of local people, MPs, but I asked a lot of people in the department, NHS England, and all the rest. And they just said, well, it's not going to happen. It's just not going to happen. It's just silly. So there's no point in having a plan that isn't going to happen. So that's when we came back and said, look, we're not going to win an argument for centralising. We're not going to win an argument for Kettering losing its ED or MAT unit or whatever. We're not going to win a hot and cold argument. We're just not going to win them. And the amount of political capital that you spend on that is vastly outweighs whatever else you can do. So the model became, we are two acute hospitals taking advantage of collaboration. And that doesn't mean there won't be service change. It doesn't mean we won't be, all cardiology will be in Kettering, cancer will be in Northampton. Obviously, it will be outreach and everything else. But we have to, whatever the next step is, we can't build it on having been told we were lying about the first step. So that's the consistent bit. We have to stick with that model, and each change has to justify itself.
Thank you. Yeah, really interesting. It all depends on the history, doesn't it? And you did mention, Alan, the new acute collab becoming both sort of commissioner and provider around elective, I think was the example you gave. And David's asked, could you tell us a little bit more about that? So is the new ICB planning to sort of formally delegate functions and funds to you as a new acute collab? Can you tell us a bit more about that arrangement, how it's emerging?
Well, it's as everybody knows, we're still in early days. ICBs start in shadow form next year. But being a single county, we are the only acute provider in the county anyway, give or take the private sector, obviously, and so on. But we're a major acute provider. And the ICS in its preparatory stage set out 4 priorities, not surprising ones: mental health, children, elective, and frailty. So various people were agreed to lead various collaboratives. And each of those would be a collaborative. Each of those would have powers and money delegated to it. Each of those would be rich in partnership and engagement and all the usual nice words. And we would lead the elective one. And I take that very seriously. We have to prove we're better at this than what went before. And that's not like having more of the same. It's not enough to, more of us is not the answer here. So we have to prove we're better when we do this and we plan this than whatever went before. And I mean, that's kind of a challenge the board is throwing very hard at the people leading the elective collaborative, which is our people. And again, I mean, one of the reasons we created all these posts for collaboration was partly to allow the people doing them to play into the ICS. So our CDIO is the CDIO lead for the system. Our CPO is the joint chair of the people board. And our chief exec spends a lot of time on system issues. So we're great believers in the system. We don't see it as a way of sort of gaming the system. We see it as a way of actually showing that this model of collaboration is rather better than the one people have played around with for 30 years.
Thanks, Alan. Now I'm conscious we've just got Ify with us until 11:45, so I'm just going to do one more question, then we'll move into his presentation, if that's okay. So Deborah, I clocked your question around NEDs, and we'll perhaps come back to that a bit later on, because it might be something others want to add to in terms of their answer as well. So I will ask that question, but just a final one for now for Alan. Danielle's interested in your comments around the political capital involved in trying to change either ED or maternity services. I don't know if there's any more you can say around that decision, whether you felt limited in the service reconfiguration you could make there, or whether you're kind of comfortable that this is the right way forward for now.
We're comfortable it's the right way forward, is the short answer. You know, they're the two biggest towns in Northamptonshire. They're 16 miles apart. There's a rubbish road between them, and neither of them would have had the capacity to do it. But actually, what really made it a kind of unarguable one was that, completely unbeknown to us and without us doing anything at all, somebody stood up, I can't even remember who it was, who stood up at the Tory party conference in 2019 and announced that Kettering was part of HIP 2. And I remember watching that and thinking, what did he just say? And suddenly we had a load of money, which was starting off with, well, it was meant to be 400 million, and it was going to start off with rebuilding our whole emergency department and everything else that went with it. So it would have been kind of difficult to change the plans at that point. And as I say, that was a complete surprise. We had never put a bid in. We had never asked for anything. We'd never played any political cards. It just came out of absolutely nowhere. And it just changed the kind of political dynamic quite hard, actually, at that point.
Thank you. Really fascinating insights. Well, thanks so much, Alan. We'll keep you here for our kind of panel Q&A at the end, if that's okay. But now I'm going to turn to Ify for his reflections on life at Oxleas. Thank you.
Thank you so much, Miriam. I've got some slides, unlike Alan. I'll try not to PowerPoint people out, so to speak. So I'm going to do two things. The first is just take you through what is now a 5-year journey of the South London Partnership, and then I'll spend a few final minutes just talking to you about the next steps ahead with respect to provider collaboratives in my patch. Next slide, please. So we three trusts across South London. Oxleas, mental and community health, and we also do quite a significant amount of business in prisons, including all of addressing all of health for people in prisons in Kent and London. SLAM, South London and Maudsley, an academic institution, also provides local mental health services in addition to a sizable national contract for specialist mental health, and then South West London and St George's that provides mental health across South West London. So the three of us came together about 5 years ago now with the sole intention of improving care, and by that I mean starting essentially making sure that people who were all over the country received care closer to home, and that their experience was more positive, and that we drive good value for the NHS. You see there what the population we're talking about is in terms of our patch, 12 boroughs, about 3.7 million, 2 ICS footprints, South East London and South West London, total staff number of about 10,000. Next slide, please. So as a partnership, we had a very clear vision, and we had what I consider to be a very well articulated strategic goal, which was something that we all shared, the three organizations shared. And we were keen in particular to ensure that by this year, we didn't send people out of area. So our focus 5 years ago, obviously very different from where we are today in terms of provider collaboratives, but this is a story that I'm telling you, and then I'll come on to what we're doing now. Next slide, please. So just a brief overview of the population we serve. As I've said, 3.7 million, very diverse population, significant deprivation in 4 of the 12 boroughs, Lambeth, Southwark, Lewisham and Greenwich, quite deprived, falling to the bottom 15% of deprived areas in the country, and broadly similar rates of mental illness compared to national average. Next slide. Our children and young people, I would say, have quite concerning levels of needs, both physical and mental health. And a significant proportion of them have had professional service contact when we looked at the data. Next slide. And adults were really no different. They had needs, but in particular, when we looked at those with severe and enduring mental health difficulties, it was evident that their physical health checks were not completed. In fact, quite poor. I would say, and even those who are known to our services didn't have adequate crisis plans. Next slide. So in 2016, we became a pilot site for what the NHS England called new models of care, and so we adopted the new models of care involved 2 main areas: forensic and children and adolescent mental health services. So we put together a memorandum of understanding for the 3 trusts. We also had similar agreements with NHS England, and at the same time embarked on a nursing development program. This was not as a result of the pilot, but this was one of a strand of things we set out to do as 3 trusts who broadly do similar work, look after the health of people in South East London. We had a series of programs that we thought we ought to do together to improve both patient and staff well-being. Today, we have a contract from NHS England of 110 million, looking after 3 strands of work: forensics, CAMS, and adult eating disorder. And a couple of years ago, we asked the CCG to allow us to take over complex care. These are people who are funded by CCGs, but not necessarily in any of the 3 mental health trusts, but they could be anywhere across the country. And often that happens because there aren't enough people in one organization to provide such care packages to individuals originating in that area. And so CCGs will buy different places. And so we've had to bring them back. And we've had a number of other programs in addition. Next slide, please. And so in terms of the lessons, really, I think one of the things that's made us really successful is that we've been very clear. The senior leadership, executives and non-executive directors across the 3 organizations have been really, really very clear about doing this together, and the message has gone right through the organization. But perhaps more importantly, we've allowed clinicians to lead with patient involvement and co-production. And those 2 things have really, really made the difference. Of course, other things like having very clear aims, shared principles, and also being very responsive and flexible have contributed, I would argue, to the success we've achieved to date. Next slide. So the next few slides are rather detailed, and I don't expect you to read them, but of course, I'm sure Miriam and colleagues will share them. But just a few points to highlight in terms of the outcomes so far. So if you take the forensic pathway, we've had a 36% reduction in out-of-area patient placements. In other words, people no longer go outside of the South London footprint. We've had 66 reduction in readmissions, which wasn't the case previously. And we've managed to invest money that we've saved in new services. So we've expanded our community forensic outreach services. We've created specialist step-down support accommodation for women. And we've managed to engage more non-statutory providers who would either support users of services in those community settings or actually provide the housing and work jointly with us. If you look at CAMS, again, 93% reduction in out-of-area beds. And here's the thing that really, really excites us, the fact that prior to us coming together, children were placed 73 miles away from home. Now it's down to 7 miles away from home. Huge, huge difference. And we've also developed other services that we think are really important. For example, in Oxleas, we've developed a DBT service for young people who are suicidal, which has reduced suicide attempts from 24 down to just 1, in the cohorts that are being looked after. A&E attendance has gone down from 23 to just 2. Bed use down to nothing for that cohort who are being managed. And of course, in terms of our complex care, which is, if you recall, is the CCG funded places, we've managed to step down 115 patients to less restrictive settings. Just the data to date. Next slide, please. And of course, I talked about a number of other arrangements or other programs that we're running, but we've got huge benefits to staff and the system in terms of improvement in workforce retention, and of course the savings that we've made so far. And it always helps when staff and patients go to places to receive awards, Health Service Journal, Nursing Times, etc. That really does boost morale, because to them it's as good as being told what you're doing is great, and it's quite innovative. Next slide, please. So because you're going to receive the slides, you have all of this. This is yet another way of representing some of the benefits that we have realized. Next slide, please. So just thinking about some of the things that matter hugely. I've talked a bit like what Alan said. If you focus on patient care and you just make that the absolute priority, if you draw in users of services, as we've done, and they've really championed some of the new developments, particularly some of the community-based services we put in place, that makes a real difference. The senior group showing that they are committed to it and unrelentingly and constantly supporting this, talking to people, having events, workshops, etc. I haven't talked much about the governance arrangements. So we have project boards that services are part of. We have program boards, and then we have portfolio boards where we all come together. Each organization has its own partnership committee, and then we have the committees in common where we have the chair, the non-executive directors, and some of the executives coming together to just review what we're doing and what else we need to do and how we improve the way we work. Service user, next slide, please. Just thinking about service user engagement. Anyone who knows me, I don't know who is in the audience. I don't think we do enough of it. So we do a bit. We take service user feedback. We act on those. We have patient stories at each of our partnership committees in common. We have services representatives on pathways program boards, and as I said, we've co-produced some of the work with them. But I really want us to go further, and that's the challenge that we constantly put back to our teams in terms of how can we be sure. So we're currently bidding for the perinatal, shall I say, contract from NHS England, and we have got services in there, just making sure that whatever we design will be right for them. Next slide. Although my next slide says thank you, so the principles, I don't think that I want to go into much of what's on this slide, because these are things that I have already talked about. Perhaps I could just spend a minute or two just talking briefly about where we are now in the new world of ICSs, ICBs, etc. So if you we already know that, largely speaking, most places have acute provider collaboratives, mental health provider collaboratives, and either community health provider collaboratives or networks. So for me as Chief Executive Oxleas, we play a part in all three. So with respect to our acute provider collaborative, our part is a small one in that we run Queen Mary's Hospital, which is a cold site. It doesn't have any A&E, but what we have there is all our acute partners providing care from that site. We've got theatres, we've got cancer treatments and diagnostics. We obviously provide our mental health services, we have urgent care. And so we see our role as being critical to the recovery plans. So we have a small part to play as part of the acute provider collaboratives, and the main members of that APC are Guy's and St. Thomas's, King's, and Lewisham and Greenwich Trust. Community health is a network, and I chair that, partly because it's a network as opposed to provider collaborative, because many of our contracts are integrated and plays a significant part. And so we've agreed to a network where we share ideas, etc. And we've also agreed to a core offer that we would have in South East London across all 6 boroughs. And that's the way we are approaching that. There's some conversation about delegation in terms of what's delegated to place and what's delegated to the network. And then the mental health provider collaborative, because the South London partnership sits across 2 ICSs, Southwest, which is South West London St. George's, and South East, which is ourselves and SLAM. We've decided that we'll probably have 2 arms, one representing and addressing the needs of the Southwest, and one representing and addressing the needs of Southeast. And we're still working through trying to figure out the detail. And the agreement in South East London ICS is that community mental health will be largely discussed and held at place, and things like complex care that we already manage, as well as beds, will be stuff that the mental health provider collaborative will be involved in. And the other thing that's really important to me is how we ensure that all our partners, not just providers of secondary mental health, but primary providers like Mind, the local authority, as well as partners in non-statutory sector, are part of what we do. And so what we have decided to do is to use a mental health transformation board. That's where we bring all our partners together to begin to think about the issues, and that would include our place leaders too, to think about what the issues are, what we want to drive forward, and how do we iron out who does what, and going forward, ensure that we can strike that balance between place and the mental health provider collaborative. Next slide. And that's me done. I hope that was clear and succinct. Happy to take any questions. Thank you.
Fantastic, Ify. Thank you so much. I'm mindful of your time, but I'm hoping we can just steal a couple of questions. So a couple from the chat, a couple of people interested in So fantastic journey and amazing benefits that you set out there for us all, which we'll share in terms of the slides. If you could kind of distill what would be your what were the key drivers in your mind? If you could just opt for sort of 2 or 3, what would you kind of pull out for colleagues?
So the key drivers, well, so you may ask the question, why did we do this 5 years ago when no one was thinking about this? So the key driver was that we often got into rooms, this was STP time, got into rooms with our acute colleagues who, as you can imagine, guys and Tommies and Kings, and all the discussion was about the problems our acutes had. And we thought, we're never going to get anywhere with this. And we decided that we'll come together as mental health and actually do something that will be of benefit to our patients and that the NHS, that will bring value to the NHS. And so in our brainstorming sessions, that's how we thought about forensic, because we were spending so much money all over the country. Children were struggling, and also we were very keen to bring resources back into our patch. So that was a major key driver to what we did then. And obviously, as time has gone on, with the successes that we've had, particularly drawing in service users and also making sure that our clinicians were leading this, we've kind of improved and implemented and gone on to other things. So that's in terms of key driver. And of course, success, as they say, sometimes makes you to think more broadly and become a bit more ambitious. And I think that's what's really happened here. That as time has gone on, our clinicians have become really quite energized, really interested. And so they typically bring to the table new ideas or new things we can venture into. We discuss those with service users, etc., and then take a view as to whether that's the direction we want to go into. Hope that answers the question.
It does, thank you. And what is kind of next on your agenda or the partnerships agenda? Is full merger on the table, or are you comfortable with the collaborative arrangements, or is there anything you can say around what's kind of next in your mind, what you'd like to achieve next?
So full merger is not on the agenda. It's not an option. And that's been the question that people have been asking for the last 5 years. Oh God, what does this mean, right? Especially now that we've got a passport, staff passport, so staff can move from one organization to the other, etc. So full merger is not on the table. We are 3 organizations that still, broadly speaking, retain our cultures and our characters, and we know that when you merge, you spend God knows how many years trying to address the culture. So we're quite clear that we can do more in a collaborative way. So that's the plan, that we remain collaborative. There are a number of other things we're thinking of, which are out with the whole provider collaborative arrangement we're all talking about today, such as doing research together, making sure that we consider for acute psychiatry, for example, we're thinking of a joint female intensive care unit, so we don't have to build one on each of our 3 sites, whether we can get to a point where we can have a common bed base, some of those issues that we think we'll be able to do, remaining 3 separate organizations.
Fantastic, thank you. I think we probably do have to let you go in a minute, perhaps if I could just sneak in one final question. Sure. You talked about service user engagement being key, didn't you? And you gave us a few sort of practical examples around that. I just wondered if there were any sort of particular mechanisms or ways of doing that that have been a game changer for you that would be helpful to share. Yeah.
So I think we've done that most successfully in our forensic services. And I think that's simply because, certainly in Oxleas, the forensic service has had a real tradition of engaging users of services for a variety of reasons, not least the fact that average length of stay is 18 months, right? So you've got them there and you have to engage them in any discussions, any decisions you make. And so we've relied heavily on that, using them as a sounding board, etc. And that's been really good. But now that we're doing more in the community, we're also doing our absolute best to do a similar thing in terms of bringing users of services together to just hear what their thoughts are about where we go next and any ideas that they think we should explore. So frankly, I mean, I worked for many years in acute intensive care psychiatry, and the happiest periods were when we collaborated with our patients. The unit was calmer. People often wanted to come into an intensive care unit from acute wards. I don't know if the audience understand what I'm talking about. The acute ward is the door is open, intensive care, the door is locked, and people would rather come into a locked ward simply because they felt that they were listened to and that they had a say. Didn't affect their length of stay. We still got people out. So for me, as a clinician, as an individual, I'm convinced that the way forward, particularly as we get into this whole integrated care arrangement, is to really, really do whatever we can, be it with Health Watch, be it with creating sounding boards, whatever, wherever we can find those partners who will lived experienced practitioners are also really hugely helpful. We need to make sure that we find them and we rely on what they say to us to build our services going forward.
Thank you, Ify. Really rich and an inspirational presentation there. I'm going to let you go to your next appointment because I know we're sort of holding you up a bit cheekily now. And also really looking forward to our next presentation from Sam. So thank you so much, Ify, and we'll turn to Sam for her thoughts next.
Thank you. Bye-bye.
Bye, Ify. Thanks, Miriam. I'm going to be a bit like Alan, and I haven't got any slides. I'm going to talk for a while and hopefully leave some time at the end for any further questions. So as Miriam said, I'm Chief Executive of Sussex Partnership. We're a foundation trust down on the South Coast, headquartered in Worthing, and we deliver services across 5 integrated care systems. We're a mental health and learning disability provider, and I guess, like all mental health NHS providers, we've got a fairly long history of working in partnership with a number of organisations, other mental health trusts, our partners locally, but also the voluntary and community and social enterprise sector as well. I remember many years ago operationally managing services, setting up services where we were actively collaborating, particularly with third sector providers in the delivery of care. So this is something, partnership obviously being in the name, is something we've got in many forms, many different forms. I was really struck when I looked back at collaboration and what collaboration means, and went back to the dictionary, the action of working with somebody to produce something. Interestingly, it also talks about traitorous cooperation with the enemy. And I did chuckle there because that did make me think about actually the landscape, particularly across statutory services and how people are sizing up provider collaboratives at the moment, opportunities to work with each other. And I think I'll come back to this in learning points, but the purpose, the why, is really, really crucial, really crucial. A bit of a story to get going on collaboratives. About 7 years ago, we were approached as the FT mental health provider on our patch with a strong balance sheet, with a strong track record of governance, by some providers who wanted us to partner with them on some very significant large tenders. Our commissioners across our patch were running 3 huge tenders, competitive tenders for the delivery of musculoskeletal services. And our partners, who became our partners, were wanting to bid for those. But they were slightly compromised because they didn't have the necessary financial backing, governance in order to do that. And they also wanted to head off some competition at the pass. There were a lot of large private sector organisations eyeing up that opportunity. They invited us to join the partnership because they wanted us to do the financial governance, bring our balance sheet to the table, and particularly lend some capital. We were quite curious about that at the time. We looked at it as a serious opportunity, and actually, whilst we could bring those things to the table, the thing that really got us quite excited was the opportunity to integrate both physical and mental health along a pathway of care that had predominantly been very acute hospital focused, hip replacements, knee replacements, and really look at actually how do we transform this pathway and how do we transform mental health care into it. And fairly rapidly, we formed a partnership of 4 different providers, all of us bringing something different to the table. And in the early stages, all of us dancing around our handbags around actually who was going to lead this, who was going to pull it together. But I'll shortcut because it's a very long story. We were successful. So we were successful as a partnership in 2 of those bids. And actually, when it came to signing on the contract, what we decided to do, given the scale of what we were taking on, was as 4 providers, 2 of the providers took the lead in one delivery of one contract, and ourselves and one of the partners took the delivery in the other. We had to think about how we structured it. We had to think about, were we going to employ staff in it? And as the FT in the partnership, our board was really concerned about the risk, the financial risk, because this was quite a novel contract. This was a 5 + 2 year contract to be the prime provider, which effectively meant you were taking all of the financial risk for musculoskeletal services. That was a massive deal for a mental health FT. How are we going to mitigate this risk? And over the 5 years, the financial value of that contract has reduced. We had a fairly strong risk appetite, guided by what's in the best interests of our patients. We wanted, as I said, to integrate the physical and mental health care pathway. And we wanted to learn about these types of collaborations because we had the foresight to think this is what's coming in the future. I sit actually on a limited company. We're what we call a thin joint venture, and we are responsible for the delivery of all musculoskeletal services for East Sussex. We file accounts at Companies House every year, and our FT carries the risk in terms of the financial value of that contract. What we've done over that 7 years is we've transformed the pathway. So we took diagnostics into the community. We have put shared decision making at the heart of this. We have extended scope practitioners. We run our own referral assessment centre. We have a pain management pathway running alongside this. And this is everything from hands, feet, hips, knees, everything from self-referral, physio, right through to elective surgery. And we run a supply chain with a number of organisations. The main partner we partner with is they have a charitable status, but they are a fairly long-standing provider of community-based physio, and they run 2 hospitals. They're not NHS, and we work with a number of NHS partners as suppliers into the service. We have reduced the cost of services for the population we serve over the last 7 years. We've remained financially viable, and we've got prems and proms at the heart of what we do in terms of improving patient-reported outcome measures and experience. And when we configured our board, we created a patient director role that sits alongside all of the directors in the board. So we really put co-production and co-design with people and our local population at the heart of this. It's been challenging in places, particularly around thinking about choice. We've run the gauntlet of thinking about when we're offering true choice to patients, what that means in terms of the workforce for the local acute trusts. And we're coming to the end of our 7-year contract. We've learnt loads as an organisation. It's enabled us to go on to do further provider collaboratives, and we're moving into a new era, obviously, of more system working. At the moment, we're in conversations about how we transition our role in that partnership to one of our local partners who would be better placed to lead that into the future. And we'll retain involvement in delivering the pain management pathway. But what it did was, as an organisation, it enabled us to think about provider collaboratives. And similar to Ify at Oxleas and South London and Maudsley and South West London St George's, back in 2018, we set up working with a number of partners across the South East, both NHS partners and independent sector partners, a number of provider collaboratives. And just to share one really quickly, which is what we call the Dorset and Wessex CAMS. So that's Dorset, Hampshire and the Isle of Wight. We are part of a partnership of several providers, NHS and independent sector. We came together to form our collaborative. to take the delegated commissioning responsibility from NHS England for specialised Tier 4 services for child and adolescent mental health. We've been running that now. It's the first of our 5 provider collaboratives that we're involved in to go live. So we've been running that now for 3 years, 1 year in shadow form, so we didn't take the financial risk. The last couple of years, we have had the full responsibility for that delegated from NHS England. And what we've done is we've saved £2.5 million over that period. And we have a commitment to reinvest all of our savings back into pathways and to particularly get upstream with early intervention. What we're essentially trying to do is to spend the taxpayers' pound in a better way to deliver better, more local care for children and young people, and where we can prevent the need for hospitalisation, because all of you will know here at the moment trying to get a CAMHS Tier 4 bed is like hen's teeth. So we have to develop alternatives, and all the evidence, and our clinicians have been telling us this for years, is if we intervene early, if we have alternatives, if we don't just work across health, we work across social care, we can do much better for our children and young people. And again, without repeating what everybody said already, clinical leadership, absolutely the heart of it. So we have dedicated clinical directors for these collaboratives. We have a dedicated leadership team for the collaboratives. We share risk across the collaboratives. So every member of the collaborative has an element of financial risk. Everybody has to have skin in the game. I don't think our collaboratives work if the lead provider simply means that you are taking all of the risk for all the populations, particularly when we're thinking about more place-based care. So we have very detailed contracts, memorandums of understanding. We found particularly, these things take time, time to develop, and it's time well spent. So just by way of summary, just in terms of the key learning points, I actually think we've had some of our best collaborations formed out of competition. We've learned quite a lot of those, but we're moving into a different era where integrated care systems and integrated care boards, in my view, ideally, we don't want to be, designing service specifications. We don't want to have an era of competition, but we recognise that all of the providers in the system have got a set of skills and knowledge. And it's not to say one is better than the other, and each bring different assets to the table. Sometimes that's in their specialism, sometimes it's in the scale and the size that they can bring, sometimes it's with the financial backing that they bring. So every partner brings a different set of strengths to the table. In the collaboration, you do need somebody who's organising things, and that needs dedicated resource. And then you need to think about that from a governance perspective. So being an FT, we've actually set up a commissioning arm of the organisation. So we've got some sort of clear water, because we're also a provider, we're providing services. And these provider collaboratives, you're not just responsible for the financial governance of it, you're responsible for clinical quality. And where you've got a supply chain, somebody again has got to have oversight of that. So you need to think about the different functions of it. But I suppose the sort of key thing for me, and Alan touched on this, is building trust. And if I go right back to 2014, when we were forming our MSK partnership, one of the things I really learned from that was, and I had my fingers burnt quite badly, I was a commercial director then. And I remember when our partners were really sort of thinking, well, you as the FT can just bring the financial balance. I'm thinking, well, yeah, but we'll be taking all the risk, and our board will have some, I called them red lines at the time. And I remember sending these out thinking, well, I'm just being really clear about what we need. And then our partners misinterpreted that. And because some of this underlying is about power, who has the control. And therefore, my sort of 2 other points would be, when you set up these collaborations, it's a bit like all partnerships, 50% of them end in divorce at some point in time, or you will go through a honeymoon period and you could get into dispute. So you need to be really upfront and really clear in however you structure your partnerships, whether it's through a memorandum of understanding or a legal agreement, dispute resolution. And what I would say is lawyers, oh my goodness, you could literally, the NHS NHS could just get out its checkbook over the next few months, because we could be racking up legal costs. You know, if you have a partnership that involves 4 partners, then if you get lawyers involved, so really think those things through in advance, think about how you can do that. I think we all need to be far more open about how we share our documentation, and maybe that's something NHS providers can support into the future, around some of those agreements, and we can sort of all learn from one another, because no one collaboration or partnership is the same. There will be some that are similar, but ultimately this still comes back to all of us, first and foremost, parking our organisations, but recognising everybody brings something to the table, investing time in the relationships. This isn't stuff you can do, frankly, over email or Teams. You know, you really do need to invest time getting together. And also recognising the really important value of what I call the experts by experience, who are our patients, our communities, the citizens, and really involving them from the outset.
Fantastic, Sam. Thank you so much. It sounds like a range of really interesting models. So we've got a little bit of time, and we've got some questions in the chat. But I wondered if I could just pick up where you ended, really. So you talked about sort of co-production with the community. I just wondered if you could say a little bit more about how that works, particularly when you've got quite a complex legal model on the table. Did you get into that detail with the community, or were you, I suppose, maybe more focused on the outcomes? I don't know if there's any more you can say about how you found a way into that with people.
I think far more focused on the outcomes and the purpose, and having experts by experience in the room from the outset. So with our more recent collaboratives, you know, where we were forming the partnerships, we've actually have paid appointments, people who come around the table to support us with that. And, you know, they have various reference groups, whether it's participation groups in communities, but they are there to be that voice, lived experience as well, bringing that into the room, because the collaboration, it's a sort of the joint venture of, you know, what are you doing and why? And so quite often it's a bit like, you know, our clinicians would have all of the ideas around the things that we need to address, to either prevent ill health, prevent cost, prevent deterioration. People with lived experience, absolutely the same. So it's a sort of nothing about me without me approach.
Thank you. And just a question from the chat as well, thinking also about sort of bringing people along with us. There's a specific question here around EDs and NEDs whose sort of natural allegiance might be to quite a traditional conception of the trust. I wonder if there's anything you can tell us about bringing them along the journey.
I mean, you have to involve them at every step of the way. So I'm just thinking about our journey with MSK. It's the one thing actually in my history on this board that was voted on by the board, particularly given the financial risk. Excuse me. We had one NED who voted against it at the time. But what we did was lots of engagement with our NEDs at various steps in the way, in terms of explaining the rationale, the benefits, clearly the risk as well, and how we're mitigating some of that risk. But a lot of this links into board appetite. And I think when, you know, you're doing board assurance frameworks and you're looking at collaboration, it's worthwhile having that conversation early with the boards.
Yeah, and it is a journey, as you say, isn't it? The arrangements you talked about have developed over a number of years. Really interesting. Well, if Alan's still there, I might have a final couple of questions perhaps for both of you. So I don't know if either of you would be able to tell us if there's kind of one thing that you'd wish you'd known at the outset, at the kind of beginning of the journey, which would really helped you, or two things, if one's just too difficult. But that would be really interesting, I think, for colleagues to hear. Sam, I don't know if you've managed to grab a drink of water, if you want to go first, sorry.
Time, this takes a lot of time. And I think one of the things we've learned over the years is you have to invest in it. So I think it does need this isn't stuff that can be tacked on necessarily to people's day jobs. It needs dedicated capacity and capability. I think at the start of every collaboration, taking some time to get a deeper understanding of partners, what makes them tick, what their values are, where are the differences. You know, that sort of old saying, culture eats strategy for breakfast, it will get in the way every time. If you think you know, you might be sat in your own boardroom or meeting, plotting out a collaborative or a collaboration or what you want from it. Are you asking your partners what they want from it, and how do you create the space for that trust? And I think, as Alan said, it's trust is earned, but it's very quickly lost. And so again, investing the time to do that is really, really crucial.
Alan, would you add to that?
Yeah, I mean, something similar, really. I think, I mean, it may not be the case that mergers or acquisitions or collaborations or whatever we happen to be doing at the time is different in the health service from other public or private sectors. But it kind of feels as if it is. And I think the difficulty of getting other people, I mean, look, whether that's counsellors or non-execs from a different background, to understand the kind of intense human factor stuff in this, the intense emotion stuff in this, is really quite difficult. And the byproduct of that is getting getting people to understand and that these are big decisions that boards are making at that point. And they're decisions that are going to resonate for quite a while. And back to my water slide stuff, this is going to be pretty bumpy on occasions. So I think it's the same sort of thing. I think it's about time and commitment and understanding. These are not like, you know, oh yeah, that's a good idea, Alan, let's just agree to do that kind of debates, you know.
Well, thank you both. Thank you both. I'm sort of looking at the time, and we have got more questions we could have asked, and I've got so many more in my mind as well, but I'm conscious of everyone's diaries. So we're due to finish at 15:15. So I think I'm going to let that be our last question for now. But thank you both so much, and to Ify as well, for really rich and very frank and honest presentations as well. So I think my takeaways, which I'll be really brief around, were I like the sound bites around consistent and persistent and meaning it. I thought that was really, really effective. And also Sam's sort of unpacking of the term collaboration and actually focusing on the purpose and the benefit for patients and communities is what's going to drive us forward, which was really consistent through all three presentations, I think. So what was really clear from all three was the degree of benefit that can be achieved, and also I think the hard work and leadership time that underpins that. So thank you to all of our presenters today, so Alan, Ify and Sam. It just falls to me really to remind you that a link to an evaluation will be going in the chat. If you can tell us what you found most useful and what you would find more useful in the future, that would be great, because we take that really seriously in shaping our programme. If you want to drop us a bit of quick feedback in the chat, or a thumbs up or thumbs down, that would be really useful. Also, we have got another couple of events scheduled for February and March, and the team will send round details to all of you with a write-up from this session as well. So thank you again to our presenters. Really inspiring morning, I think, and fantastically rich content. And thank you all for making the time to join us, because I know it's busy for everyone out there at the moment. So thank you so much. I hope to see you again soon in the early new year. Bye for now.